Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. So excited to have everyone here today. So as you can see, we have a little bit of a different screen because we're having some technical issues, but we are still Airway Answers with special guest, Dr. Jerald Simmons. So I'm going to introduce you, Dr. Simmons, and I'm sure most people probably already know who you are, but I'll go over all your background because it's so important to know the history of your studies, where you came from, all of your experiences. And then we're going to talk about the wonderful Sleep Education Consortium that's coming up in April. And really the topic as well of what we want to review today is bruxism. I want to talk a lot about bruxism because I think a lot of people have confusion on what clenching and grinding of the teeth is, what are potential causes. I see so many questions on social media from different patient groups as well. So let's go over that. And okay, my puppy is on my lap. Sorry, I have a little puppy. I have to make sure she doesn't bark. So she's on my lap moving around. So if you see a little Coco, that's what that is. Okay. Dr. Jerald Simmons is triple board certified by the American Board of Clinical Neurophysiology, American Board of Psychiatry and Neurology, and American Board of Sleep Medicine. He's the founding director of Comprehensive Sleep Medicine Associates with locations across Texas in the Woodlands area, the Houston Medical Center, and Sugar Land. I think I've been to two of your offices.
And Austin.
And Austin, that's right. I've been to two of your offices before for my PES, pharyngeal esophageal manometry sleep studies, which is the gold standard for diagnosing upper airway resistance syndrome. And you really saved my life, changed my life with the sleep studies that I got at your sleep labs. Dr. Simmons also founded and directed the Sadler Clinic Sleep Disorder Center from 1999 to 2012 and is the founding director of the Sleep Education Consortium, which is a 501c3 nonprofit organization that focuses on enhancing the education of doctors and the community on sleep disorders. We're going to talk a lot about that today because that is a wonderful conference coming up in April that everybody really should attend. So we're going to go over what that is. And really the goal of this nonprofit sleep education consortium is to educate the healthcare community and the public. So not just medical and dental professionals, but also the public on a variety of sleep and airway disorders. And the Sleep Education Consortium by Dr. Simmons and I have joined forces recently. And my Airway Answers podcast and interview series is going to be a subsection of the Sleep Education Consortium. So if you go to sleepeducation.net, you can find information on the Sleep Education Consortium, the upcoming conference, access to all of these podcasts and interview series that I'm doing as well. So our goal is to just help the community learn more about sleep and airway disorders. So a little bit more, let's go into more detail about Dr. Simmons, who also received a neurology degree from Washington University and went on to obtain a fellowship training in sleep medicine disorders at the Stanford University Medical Center, where we know Dr. Christian 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐿𝐿𝐿𝐿𝐿𝐿 was there and you worked closely with him. And then you received neurophysiology and epilepsy training at University of California, Davis Department of Neurology. Upon completion of his training, he joined the faculty at UCLA and held the positions of co-director of the UCLA Sleep Disorder Center in Los Angeles and director of clinical neurophysiology laboratory at UCLA, Allevue Medical Center in Sylmar. Wow, I didn't know that. While there at UCLA, he was active in training other physicians in sleep disorder medicine, and after 6 years, Dr. Simmons transitioned out of UCLA into his current positions. So currently, as a neurologist, Dr. Simmons treats patients with a wide range of neurological conditions, but spends most of his practice evaluating and treating patients with sleep disorders. One thing that's really amazing about you, Dr. Simmons, is that you have your board certification in sleep medicine, but also neurology. So that really important link between the brain, neurological connections, and sleep disorders, I feel like is really important. I find a lot of patients who might have airway problems also have non-anatomical sleep disorders, perhaps like narcolepsy or other things that we wouldn't pick up on without a really highly trained sleep doctor and neurologist on the case. So I think that's a really great combination of skills that you have. Dr. Simmons has dedicated his career to providing the highest level of diagnostic testing to identify the full spectrum of sleep disorders. You've been on the cutting edge of implementing new technologies in the sleep laboratory, including esophageal pressure monitoring, which is the PES, to diagnose patients with upper airway resistance syndrome, a sleep disorder characterized by airway resistance during breathing during sleep. Dr. Simmons evaluates pediatric patients as well as adults and is among the few sleep specialists in the United States who can competently diagnose children who have hyperactivity attention deficit disorder caused by a subtle sleep disturbance such as UARS or periodic limb movements of sleep. Implementing state-of-the-art technology has been a passion for Dr. Simmons, and he's actively working to implement new technology in the field of medicine and more specifically sleep disordered medicine. Dr. Simmons is committed to teaching both medical professionals and the general public on sleep disorders. As the director of the Sleep Education Consortium, Dr. Simmons coordinates ongoing conferences to enhance the knowledge of sleep disorders of the healthcare community and general public. Thank you so much for your time. I know you are a busy guy, so
That's
the
like a
fact that I can
webinar in
get
and
you
of
for an hour.
itself, Nicole.
What'd you say?
My introduction is a webinar in and of itself.
Exactly. We only have 5 minutes left, so quickly go for Bruxism. No, I mean, it's so important because, a lot of times we're working with other professionals in our field, whether we're a patient of yours or a colleague. And sometimes we don't know all of this amazing background that you have. And it's so interesting to look back on all your training and all these important characteristics that have brought you to where you are today. And I think the Sleep Education Consortium that you're the director of is such an amazing nonprofit organization. Can you talk a little bit more about that?
Yeah, so when I left academics back in 1999, I still wanted to continue teaching and got to the point where I decided, I realized there was a deficit in our healthcare training in the community in the United States and around the world. And so, I wanted to do my part to help fill that void. And so I started the Sleep Education Consortium to do an annual conference to add more education to people that have been out in practice, but don't know anything about sleep, and they needed to have some place that they can go to sort of get up to speed, if you will. And clearly, healthcare. Look at medical schools, for example. Over the 4 years of medical school training, on average in the United States, a medical student is only going to get anywhere from 2 to 4 hours of curriculum focused on sleep disorders. And yet, we spend a third of our life sleeping. There are all these sleep disorders that occur affecting probably about a third or more of our society, on whether it's an occasional or chronic basis. And there's so little time spent teaching medical students anything on sleep. So what about all those that are done with medical school and are out in practice? Where are they going to go to get their training? So I put together the consortium to meet that need, from that deficit in education. And dentists are really well situated to identify patients that have sleep-related breathing disorders, because the mouth is part of the airway, and the teeth are part of the mouth, and the jaw structure is part of that upper airway as well. And yet, pulmonologists don't have in their formal training very much about how the mouth and how the lips and how the tongue and the teeth are all part of that upper airway, and that there are dysfunctions of that anatomical region that can be a red flag when someone notices it, a red flag that there's a bigger problem. And so reaching out to dentists became sort of a natural extension of my medical practice as I became more aware of how there's an important interface between dentistry and sleep medicine.
And I think, have you referred to yourself as a dental neurologist,
Neurodontologist
a neurodontologist,
or a dental neurologist.
or a
Yeah.
dental neurologist? You could start either field. You'll be the only person in it so far because that's
Uh,
amazing. I mean, it is so true that many other healthcare practitioners are not aware of that link between the craniofacial respiratory complex and sleep disorders. I mean, there are so many sleep doctors I work with who probably have no idea about occlusion, looking in the mouth, the role of the tongue, narrow palate, myofunctional disorder. So you have that special link and you can bring that education to the public and to other medical professionals. And one thing I always talk about is those non-anatomical related sleep issues. If you're working with patients who have sleep disorders like, upper airway resistance syndrome, obstructive sleep apnea, snoring, isn't there a high likelihood that there's a possibility there's other sleep problems that could be apparent that are not related to airway issues? Because I have seen so many patients, like I said, who have narcolepsy, and you're not going to fix that with myofunctional therapy or a palatal expansion or things like that, and that could get missed. Can you
right.
talk about that
Well,
relationship?
definitely, especially the more motivated patients. They're having a lot of problems. They're not getting the answers that they need. The treatments that they've been utilizing have not resolved their issue. So you have to then maybe they do have an airway problem, but that may not explain the entirety of their condition. And so if someone is going to be involved in sleep medicine, they really need to understand that it's not all about airway. A lot of it could be airway, sure, but they should be knowledgeable that there are other conditions that are going on. Is Other conditions that can be involving sleep that they need to be aware of, and that's why look thank you, Nicole. You're shedding a lot of exposure to me, but it's not just me. I'm not the only person on this planet that recognizes all this stuff. And so for the Sleep Education Consortium, can you see the screen?
Yes, we can.
Okay, so this is for dentists, this is a 3-day conference. And for physicians, it's a 2-day conference. So the first day is dedicated just for the dental professional or myofunctional therapists, people that are in the dental realm, because there's a lot of focus on working with oral appliances, doing the oral exam, the airway exam, how to screen for problems in sleep. And so the first day is just for dentists. And there's and the second and third day is both physicians and dentists sitting together in the same lectures. So for the medical pathway, it's a 2-day conference. It's going to be April 4th and 5th. For the dentists, it's 3rd and 4th. So this is the QR code for the dentists. And this is the AAPMD, American Academy of Physiologic Medicine and Dentistry, is another organization that I'm very involved in. I'm on the board, and Nicole also interfaces with them extensively. That's a discount code that you can use to get a discount for the conference. The medical day is, I go back. And then this is a different QR code for physicians, right, which is a 2-day conference. But you can see I'm joined by a bunch of other healthcare professionals. I'm not the only physician that can identify sleep and ADD, ADHD. As an example, for example, Kevin Boyd, who's on our panel here, he's a pediatric dentist that's extremely involved in this field, and he's worked extensively with Dr. Sheldon, who's a pediatric neurologist in Chicago. He just recently retired, but he's been talking about the same thing as me for many, many years. And there are Ron Chervin over at University of Michigan, has been involved in this for many, many years. I'm not the only one, but a lot of pediatric neurologists are not aware and don't really focus on sleep issues. A lot of pediatricians are not aware of how sleep is an important thing. My view is a child should not be put on medication for ADHD until they at least have a screening history. A physician or clinician needs to take a history looking for possibilities of a sleep problem as the underlying cause. Because if you treat the sleep in the child, then maybe they don't need to be put on stimulants. And a lot of times it's due to a small mouth, malocclusion. That relates also to a respiratory issue. and the child may be having subtle breathing disturbances during sleep. The oxygen level may be fine, but it's not all about oxygen. All right. Your oxygen does not have to drop to have obstructive breathing during sleep. Now, these concepts are extremely covered extensively, at our conference. So if you're interested in this topic, you really want to go to one conference that's going to teach you a lot about sleep. You'll learn about insomnia, restless leg syndrome. Dr. Ando is world renowned on restless leg syndrome. He's giving a lecture on that. You're going to learn about Inspire, treatment, for implanting devices for treating, apnea. So it's not just one thing. We're going to talk about a whole variety of different kind of conditions. Dr. Palayo is going to talk about insomnia. So anyhow, there's a large faculty, and I'm excited about this conference. This is the 21st year that we're doing this conference.
That's exciting. That's a big deal. And for people who are listening who might not have the video version on right now, I also see you have Dr. Stanley Liu and Dr. Audrey Yoon presenting as well. There's a variety of speakers. We have ENT, myofunctional therapy with Samantha Weaver, Dr. Mariana Evans, who I assume she's probably presenting on MARPE and palatal expansion. David Alfie, oral maxillofacial surgeon, Dr. V's, Dr. Hal Stewart, Dr. Stephen Lamberg, lots of Dr. Carstensen is there. This is a really great group of people. This is amazing.
There's a lot, so go to the webpage, go to, for the dentist, it's dentalsleepconference.com. For physicians, it's medicalsleepconference.com. There's a lot, the difference in the cost is that there's a lot of resources that are necessary for the first day, the hands-on. So, and also the pharmaceutical companies that are sponsoring this have given more subsidization for the physician pathway. So there is a difference in the cost, but the cost is really trivial when you think about the amount of education you're going to get. This conference has really transformed many clinicians' practices. I hear it all the time. So, all right. So for purposes of time, I know you want to talk about Bruxism. So why don't I talk a little bit about what's the definition of Bruxism? There's a lot of debate on that. And is it the grinding of teeth? Well, the American Academy of Oral Facial Pain have also adopted, and other groups have now adopted, that clenching itself during sleep, that's considered bruxism. So it's not just the grinding, but the clenching process goes under the definition, right? And so, but we now are starting to recognize in the medical field, I mean, I've done this for years, but now there's literature coming out saying that examining the teeth and looking at tooth wear patterns are important, because that may relate to sleep bruxism, which has been related to sleep apnea. And so as a neurologist, I mean, I took these pictures of patients' teeth. And so here I am as a neurologist looking at teeth and seeing the, whether it be abfractions or tori or just the wear pattern. Why is someone destroying their teeth in their sleep? And we've come to realize it's because they're trying to protect their airway. So I can elaborate a little bit further, Nicole, if you want me to go on a little bit more about the physiology.
Yeah, I'd love to hear about the physiology of sleep bruxism and why someone might clench or grind their teeth while they're sleeping for airway purposes. So if you can talk about that, and also maybe address like differences between daytime bruxism versus nighttime, if there's different potential reasons that you see.
Sure. Well, it's interesting because when you start taking bruxing histories from patients, I found this pattern frequently, that someone that might be a 24/7 bruxer now, when you go back in time, initially it was just a nocturnal bruxing problem. And then as they started getting TMJ symptoms, it started to evolve to now involve more daytime bruxing as well. So, when you really want to find out, could it be related to a breathing phenomena, go back in time to the earliest recollection that the person has of bruxing. And frequently you're going to find it started off just at night. I think once there starts to be some destruction at the temporomandibular joint, there's some proprioceptive changes that are taking place. And now the person is having this parafunctional, abnormal kind of activity extending itself into the day. Now, people will say, oh, the bruxing is because of the malocclusion. Well, there's a real interesting number of studies that were done on kids that were sleep bruxers, and they had enlarged tonsils. And then after taking the tonsils out, there was improvement in the bruxing. And there's no change in the occlusion, right? So if it was truly just from the occlusion, then why would it improve by taking out the tonsils? Well, that's because the obstruction improved. So let's talk a little bit more about the physiology. So here's a sleep tracing, right? And show the different channels, the EEG, the eye movement activity, muscle activity, the chin, the ECG activity, limb movements and snoring. Here's airflow through the nose and mouth, movement of the chest, movement of the abdomen. And this is the esophageal pressure transducer that you had mentioned, that PES. And you can see this increased crescendo of effort that's occurring here. Okay, this is about a minute of what we call hypopnea. So the person's working harder to breathe with each breath, but finally they're working so hard that it triggers an awakening. With the awakening, they take a deeper breath, but with less effort, because now the obstruction improves because the airway opens up with the arousal, and then they go right back to sleep. But there's increased negative pressure in the back of the airway that occurs from the obstruction. And again, we're limited on the time, so I can't go into that in great detail right now. But let's just go over this a
Can
little
I
bit.
ask one thing to interrupt, just
Sure.
in case somebody is not sure or unaware of what PES is and what that means? Can you just explain that?
So PES means pressure in the esophagus, all right? Almost like a mathematical equation. So big P, small es for pressure in the esophagus. And it is a measurement that's within the esophagus, but in the level of the chest. Typically, we do this we place a little thin mylar catheter, like a feeding tube, a little Dabha feeding tube. We place it in the nose. The patient will drink water through a straw. As they sip on the water, we slide the little catheter down and they swallow it. And the tip is right around the level of the heart in the esophagus. And then outside of the catheter, outside of the person, the catheter then hooks up to a little tubing, IV tubing, and it goes to a transducer. And that transducer then measures the pressure. So we can identify the pressure that's inside the chest, outside of the patient through the, and actually this is filled with water actually, and the transmission of the pressure through the water to the transducer allows us to measure breath by breath the changes in the pressure in the chest cavity. And so as you cause obstruction of the upper airway, you end up having more negative pressure in order to breathe, right? And this is actually characterizing this because this is the best measure of respiratory effort. It's better than the bands that go around the chest or the abdomen. This is the most direct measurement. It's the only internal measurement we're making during a sleep study. Most labs do not do this procedure because it takes more finesse, if you will, extra instrumentation. There's a lot there's a learning curve, a steep learning curve. But once the lab can do it, we do it routinely. Not on every patient, but clearly on patients in whom the diagnosis would, to establish the diagnosis, we would need this extra instrumentation. So when you look at obstruction, what's happening during sleep apnea, and we say sleep apnea more loosely because it doesn't mean complete blockage of the airway. Apnea does, but with sleep apnea syndrome, it also includes hypopneas, okay? And it also really includes respiratory effort-related arousals. It's all of these obstructive respiratory events on a spectrum that fragment the continuity of sleep. But what's happening is the mandible falls back when it's relaxed, and as the muscles of the upper airway relax, the base of the tongue relaxes, and you get the obstruction in the back of the airway, right? So by bruxing, by increasing the muscles that close the mouth, you're bracing the condyle into the fossa, and you're stabilizing the mandible forward, which brings the soft tissue, such as the tongue, the geoglossus muscle, forward, and it helps keep the airway open. So masseter tone has been shown to help increase airway patency, as well as other muscles of the upper airway. And so when you look at the physiology of the tongue, right? And this is being depicted here by EMG activity, right? And then you look at the negative pressure of the airway. So if you're breathing through a tube, all right, and now if you make the tube smaller, you now have to exert more negative pressure to get the air through, because you have to get the same amount of air through a smaller tube. There's more negative pressure. And there's been studies that will show an increase of EMG activity associated with the increased negative pressure. So it's a normal reflex of the upper airway is to increase muscle tone when it's being presented an increased challenge of increased negative pressure. Right? So it's a reflex that will help the upper airway. So it's a real interesting study done. And, again, I encourage people to come to this conference because I had more time to really explain the details of this concept. But there was a study done on patients with sleep apnea that had tracheostomies. And basically, I'll show the main finding of the study was when the individuals were breathing through the trach, which means they're not having to breathe through the upper airway, all right? Every time they took a breath, there's a slight increase in muscle tone measured at the tongue, okay, real slight. And there's no airflow, and that's measured here with pressure transducers that were in the nasal pharynx and then right at the level of the hypopharynx, and then looking at flow at the nose. Then they plugged the trach. So that over here on the left side, that's when the trach is plugged, all right? And so you can see a little bit of negative pressure, and you can see the flow. And also, you now see increased muscle activity in the tongue with each breath, right? And that increase is because you now have the flow going through the upper airway. So when you don't have flow going through the upper airway, you don't have, there's a minimal amount of burst of EMG activity, and that is amplified by the negative pressure in the upper airway for when the trach is plugged, right? So this is showing that negative pressure in the upper airway is associated with increased muscle tone of the genial glossus and other muscles of the upper airway. So there's a number of studies that have been done looking at this, but there's some challenging concepts out there. So there's a group, Dr. Levine and Dr. Cato and Dr. Julian, and just a group, they've looked at bruxism, but they've defined bruxism as this rhythmic masticatory muscle activity. That's what they define as bruxism. So all their studies are looking for that activity as that's the only representation of bruxism. But the reality is bruxism isn't always going to have that rhythmic activity. And we're finding that's more of an arousal phenomena after the actual event. So, and they've noticed in some of their studies that there seems to be a little arousal beforehand, but they're not really characterizing the sort of the protective aspect that bruxism and tonic bruxism can provide. So really, you want to break bruxism down into its tonic and phasic components. This would be more phasic, this rhythmic boom, 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 bursts, right? As opposed to a sustained activity. So we started years ago, we started adding extra electrodes on all of our sleep studies in the temporalis, masseter, and submental regions. So we basically have 6 electrodes on the face on every one of our sleep studies now. And you could see here, we noticed, this rhythmic activity also on our sleep studies, but you can see preceding it, there's a slight increase in the effort. I'll show you a better example though. Look right here. This is the PES, right? And right here, you see the increase in muscle tone. So this isn't so rhythmic. This is more sustained bruxing. And you can see the snoring stops. There's no apnea here, right? But, apnea is not always going to be occurring when you have increased obstruction, and these flow probes are not as sensitive as the nasoesophageal pressure monitors. So look here, the increased negative pressure. And right when the bruxing starts here, you see how it's reduced? So right here with this increased muscle activity of the external muscles of mastication, as I frequently refer to them, when that occurs, that opens up the airway and makes it to where it doesn't, you don't need to work as hard to breathe. So, and this is just showing the different definitions of the parts of this tracing.
Could I ask a question?
Sure.
Okay. So would the tonic bruxism be clenching and the phasic be grinding, or am I incorrect in how?
Well, okay, so the tonic would be clenching, but the phasic can also be clenching, or it could be grinding. So clearly, when you're talking about that rhythmic mascatory movement, that's going to have, that rhythmic aspect may be associated with a grinding. But you could be in occlusion and just still be having more intermittent flexing of those muscles, so to speak. You don't have to have movement. But what you do have is you have the mandible locked in occlusion with the upper teeth. And
Okay.
so you're preventing the retraction of the mandible. When you brux, you're not bringing your jaw forward, backward rather. You're bringing it in occlusion. You're going into an occlusive relationship of your TMJ, right? Or maybe you're thrusting. And there are a lot of people that will also tongue thrust. Kids will tongue thrust to overcome their obstruction. Sucking the fingers of the child also helps keep the airway open. So a lot of kids are more calm by sucking on their thumb or sucking on their fingers because of the airway compromise. And we're trying to break the habit, and we're basically making their breathing worse. But at the same time, by having that behavior, it's making the occlusion worse. That's why you want to have early intervention orthodontics. And actually, you know what? I'm going to send our friend Kevin Boyd a message right now. Maybe he's going to be able to join us in a few
I
minutes.
heard, rumor has it, he might surprise us.
Okay, so I'm going to send him a little message. But all right, so look at right here. You see this tonic bruxing, how I'm showing with CPAP. All right, so here's the patient, increased negative pressure, snoring, but when you compare it to over here, now the bruxing, same patient. See the increased muscle activity? Look at the PES. See how it's less? Right? So here the PES is more because you see the muscle activity, but it's even higher here because this is when they're tonically bruxing with even some phasic increases on top of that. They got decreased PES. Now that same person is now put on CPAP, and now you see how the muscle activity is less when you compare to these. And look, the PES is less because now the airway is protected by CPAP. And
Is that correct, Dr. Simmons, to say okay, that tonic bruxism is protecting the airway, but as that airway collapses more and you have an arousal, then the bruxism becomes phasic? And so the phasic
no,
bruxism is after the arousal, or no?
no. So the phasic is part of the arousal.
Part of the arousal.
Yeah,
Tonic
it's just
precedes
a
the
burst,
arousal.
but the tonic is more sustained.
And precedes the arousal, kind of as
Well,
the,
you're trying to protect yourself from having the next arousal,
okay, right,
right? But in
okay.
and of itself may be associated, can be causing arousals. But the point is a phasic little burst isn't really protecting from the next event. But the tonic, the sustained increase of the muscle tone will help prevent the next event from occurring. Now, not everyone demonstrates this pattern. And sometimes the apnea is so bad that the reflexive phenomena breaks down and they stop bruxing. And when you get histories of patients, when you start asking specific questions, I've had many patients where they used to brux all the time and they had all this TMJ issues. And then, but it stopped, let's say 5 years ago. Okay. And then you start asking more about their sleep apnea history and say, well, their sleepiness and their witness pauses got worse about 5 years ago. So it's like at a certain point, the compensation may break down and then the apnea itself gets worse. So, but not everyone follows the same pattern for reasons we don't yet understand. But this association clearly exists in a lot of patients. And a lot of oral pain dentists have come to realize now, and I remember I was getting criticized a lot when I first was talking about this. They said, no, I'm off the wall and whatever. But a lot of them have become sleep dentists. They've gone into dental sleep medicine as an enhancement of their oral facial pain practice because they realize by treating the airway, they're helping their the patient's TMD symptoms. They're decreasing a lot of the bruxing. So, but really, this is a spectrum of the problem right here. You got complete apnea over here. You got normal breathing over here. So it's not sleep apnea, yes or no. It's what degree of sleep apnea. And when you're on this end of the spectrum, there's more concern about cardiovascular disease. And it's also a home sleep study can be used to diagnose on this end of the spectrum. But when you start getting onto this end of the spectrum, you can't, a home study may not show you what you're looking for. And there may be bruxing as a partial compensation. So you may not see as bad of apnea. And then when you're on this end of the spectrum, you may have to add something like the PES in order to make the diagnosis, because you're arousing the person from their sleep, but they may not be having the cardiovascular consequences because their apnea may not be as bad, but it could still be frequent. And a lot of times we tabulate severity based on frequency of events. But so I've had patients that have a home sleep study comes back at normal, and then we bring them into the lab, and then I say they're severe, and they're like confused. Why? How could the home study be normal, but yet you're saying I'm severe? And that's because right now we have a one-dimensional representation of the condition as the frequency of events. And we say if the frequency is greater than 30 times per hour, it falls under severe. But each of those events may have gone under the radar to where they're not detected on a home study. But now on an in-lab study, we find all of these and they're greater than 30 times per hour. So, you got to realize that what you see depends on the tool you use to look. And a home study can be used to diagnose the condition of sleep apnea. By no means can it be used to exclude the diagnosis. You cannot rule out sleep apnea with a home sleep test. And even an in-lab study, if it's not done properly and not scored using the 1A rule, using the arousals, without relying on a desaturation, if you don't tabulate it that way, then you may miss it, or you might even need to have the PES in order to make the identification of the issues. But anyhow, I think is our friend Kevin on here now? I sent him a message.
To talk. I believe he is here. And let's
Yes. Yeah. I'm
Kevin.
here. I can be here if you want me to. Or I
Dr.
can
Boyd, Kevin
I
Boyd.
can yeah, I can go away too, whatever you want.
We want you here. We
We
love
want
Oh,
you. No, it's great. I was talking about the thumb sucking and kids with all sorts of issues with making their malocclusion worse by trying to protect their airway in their sleep. And
Yeah, actually, Dr. Boyd, can you talk about how bruxism can make the occlusion worse?
well, again, um it I'm not sure that bruxism actually exacerbates an already existing malocclusion. I mean, it can result in mechanical attrition, the wearing down of the teeth. They don't interdigitate as well. Um, but what the whole thing about thumb sucking and, being, as Jerry says, it's a protective mechanism, and it's soothing. So, if parents come to me, oh, is there something I should do about the pacifier or the thumb? Or my first reaction is, okay, you brought your 3 or 4 year old here. There is evidence to suggest that apparent life-threatening events in babies a pacifier might be protective. That's not up to me to tell you to take it away, but certainly after 2 or 3 months, it can start to interfere. And I learned this really from your specialty, Nicole, of speech pathology. Um, Specifically Kristen Miller, who was a speech pathologist that worked in my practice as a myofunctional therapist several years ago, taught me that, children, when they transition from an infantile suck swallow, and then, maturing into a mature lateralizing chew swallow, that can get interrupted and they can get an over retained infantile swallow, tongue thrust in myofunctional disorders. Well, that's what exacerbates malocclusion. It isn't the grinding so much. Well, I give that information to parents, but I also, with the caveat, it's not up to me to tell you to take away self-soothing from your child. That could be conferring lifelong psychological benefits. That's not, and I really defer to the parents, mostly the mother's instinct on this. And that tends to take a lot of pressure off of parents. Like, thank you, Dr. Boyd. Everyone else is telling us we got to get that thumb out. And, no, that's not my job. I'm here to tell you what could be harmful if it persists. But, it's not my job to tell
So
people to not do that.
Kevin, have you ever noticed that after you do expansion that the children stop sucking their thumb?
Well, and during, I mean, because they get, if you got an expander in the mouth, it takes the kid, and some kids find expanders soothing, not right away, but you can go to nighttime only, I'll tell some parents, because you're wide enough and the retention part is already done and the kid's adapted to it, and the child doesn't want to. They like it. So what I generally say is when I'm at a chronological age where the algorithm with the Bogue index and things that we measure that is good and it's been holding for 4 or 5 months, they can go to nighttime only. Um, you know, some of them just don't want to do it. So I say, well, you must wear it at least every night, but you can wear it all the time. And that's kind of something I just learned on the job, having been doing this for almost 20 years now. So
The amazing article by Linda D'Onofrio, Oral
yes.
Dysfunction as a Cause of Malocclusion, what she
Mhm.
states is that research shows that non-nutritive sucking habits is a sign of airway obstruction or tongue tie. And we see that all the time. So my office, we kind of get stuck because we'll have parents call and say, like, my child sucks his thumb. Can you help him stop sucking the thumb? And as myofunctional therapists, we have digit sucking programs, which are usually based on positive reinforcement, classical conditioning to help a child stop sucking. But my belief, and I think a lot of people feel the same way, you have to treat the underlying cause. We know that these sucking habits are usually helping open up the airway. The thumb might be functioning like a mandibular advancement device, right? Like an oral appliance that someone with sleep apnea may wear to bring that lower jaw forward and down and bring the tongue forward and down to help that person, that child breathe at night. So we need to actually treat the cause, the airway obstruction, the tongue tie, the myofunctional disorder before or as part of the digit sucking program. You don't just
Well,
want to like
what,
wrap someone's arm, give them prizes, and say, you don't suck
right.
your thumb. There's another underlying reason that that's probably occurring. A quick thing.
Another
Yep.
thing,
Mhm.
Nicole, that I'd like to say, I'm sorry to interrupt, but in children, we call them um, dentofacial orthopedic appliances. We don't call them medical devices. We don't call them, airway opening. It's what we do in with children who have malocclusion, mandibular advancement means the mandible is retrusive relative to the cranial base or the maxilla, is that again, I caution people who call them mandibular advancement devices because that's really an adult term for when you're trying to rescue an airway, whereas we never promise parents, look, I am usually when we do put a child in a functional appliance or a dentofacial orthopedic modifying appliance, there will be benefits to the breathing in the airway, but we never promise that. And that's why I like to get away with trying to confuse it as a MAD, a mandibular advancement, device. It's an important concept.
I
It
just meant
seems
the thumb, like that
no,
thumb, like
yeah,
that.
no, I know exactly what you meant.
Okay.
But I wanted, in case people are listening,
Yeah.
right?
Oh,
So
Kevin, since we have you on, let me bring up another concept here real quick. It's a little bit different than what we've been talking about, but clearly relates. And let's go back to here. So this is our conference, the consortium conference. And right here, one of the topics is going to be obstructive sleep apnea and pregnancy and pediatrics. And actually, Kevin, you're the one that's going to be doing that lecture, talking about what happens during pregnancy and sleep apnea, the impact it has on the fetus, and and the mother itself. And so, this is an area that really needs further research, and there are things that are being done right now. And I think you're going to be talking about some of those findings.
I am. I think one of the hypotheses that you, myself, and Emmett Schneiderman and Louise O'Brien at Michigan were all very curious about, as you know, the hypoxia that can occur during pregnancy and the delivery of adequate oxygen to the fetus via the placenta, that it often, I think it's recognized that preterm birth and small for gestational age, intrauterine growth restriction, those things are known to be associated with women who have difficulty breathing or giving birth at high altitude versus at sea level. These are things that have been explored in the literature for decades. Well, now we're suggesting it's not just the long bones that can be stunted in growth, but why not the craniofacial bones, which are, so that's sort of a hypothesis that I'm going to explore and try to show evidence that should lead to more curiosity about this in research.
Yeah, and this is a new area, and everyone talks about obesity and pregnant women, but what the next phase of all this will be women that have craniofacial compromise from small mandibles, high arch palates, and that are going to be predisposed to having obstructive breathing that are not obese prior to their pregnancy.
Right.
So
What
it's
if it's
not just
just
obesity.
brain or like upper airway resistance syndrome where there's not an oxygen issue that might impact the fetus? Is it that maybe cortisol?
No. Well, okay, so those issues may cause disruption of sleep
Mhm.
without the desaturation. Then the question is, how much does the disrupted sleep cause increased stress on the mother and then also on the fetus? So those are things we're looking to over time have more answers about. But clearly, we know that in obese women, there's no question about the fact that there's more sleep apnea, and that's actually a study that we've done in our practice. We actually have an NIH grant looking at this, and some of those results will be presented at the conference. But here, just another thing, just to let you know about the conference, we're actually going to talk about the GLP-1 agonist medications and how they're now being used for treating sleep apnea. Another, real, new topic. And then just also having wearables and using those for monitoring, and then the whole thing of ADD, ADHD, and how you don't need to be just putting kids on stimulants. We need to be coming up with other things to be treating, such as sleep issues, and that may alleviate the need for the stimulant medications. But also, we're going to have a talk on artificial intelligence in clinical practice and some things that are currently being done and how you can modify your practice by using AI to look at your data and help you with identifying differences in your practice patterns and how you can improve your overall outcomes by identifying associations that weren't so obvious initially. So Dr. Cheng Ron is going to be giving that lecture. It's going to be very interesting. Just a whole other, narcolepsy and SFOT also, cutting away the gums and enhancing bone growth to help with airway management in conjunction with orthodontics. Dr. Ross is going to be talking about that. So there's just a whole variety of things. So
There's a
I'm
lot,
excited.
whole wide range of topics in the sleep disorders realm. Can I ask a few more questions on bruxism?
Mhm.
Because I feel like, a lot of our patients are either referred due to the bruxism, the facial pain or tension, or a lot of patients are completely unaware that they might have sleep bruxism, but their dentist may notice that. So, is it correct that if someone is bruxing in their sleep, their AHI is probably going to be less?
Well, that theoretically that can be on some patients, but yes, we that hasn't really been shown because then how do you
Right, you're
how are you
comparing
going
them
to
to
treat them?
themselves. Yeah.
So okay, so I'm actually a co-author on a paper that was done on Botox for the treatment of Dr. Ando and I did this. It was actually published in the Journal of Neurology a number of years ago. and it was looking at TMD associated with sleep bruxism and does Botox work. And we did sleep studies on all these individuals. And at first, we had sleep apnea as an exclusionary criteria. And my whole premise going into this, and I told Dr. Ando, I said, I think we're going to give these people Botox and their bruxing is going to go down, but their apnea is going to get worse.
Yeah.
Well, what we found is that a high number of these individuals ended up having sleep apnea that was not recognized by the patients. They were going to be excluded from the study because of the presence of apnea. So a lot of these people that were coming in with TMD, with bruxing, had sleep apnea. And so we had to change the criteria and not make that an exclusionary criteria. And we ended up doing the study. Now, there was symptomatic improvement in these patients. Clearly, Botox helped, but
Helped with what?
What's that?
Helped with reducing the
Pain.
bruxism. With
Pain.
That was measured. Pain was
symptomatic.
Okay.
Pain. But we couldn't measure an increase in the apnea because the starting point, we didn't have individuals that weren't, there was already enough apnea that we weren't really able to appreciate it. We didn't measure the magnitude of the bruxing is associated with the magnitude of the apnea. Again, apnea is measured by frequency. And so there was a mild change, but it wasn't enough that would be statistically significant. But had we taken individuals that didn't demonstrate a significant degree of apnea at first, but had the sleep bruxism, which is what I was shooting for, to see if they now became to the point where they were going to have a significant degree of apnea. So we really don't know the answer to the question. Botox has been demonstrated to help symptomatically. I assume that it is going to make the apnea worse by decreasing the bruxing phenomena. But what we definitely have shown is that by treating with CPAP, there's improvement in the patient's symptoms and in the bruxing phenomenon itself. Now, if the CPAP is set to the wrong level, if they're on too much CPAP pressure, then they're going to be bruxing to help keep their mouth closed. And so it's another, again, if you got to get it just right. If you're at the right pressure, then you're going to hit the sweet spot. And then the upper airway gets unconditioned from having that bruxing as a reflexive response to for preservation. Now, what's also interesting is early on, when we first put on the CPAP, sometimes we notice that whenever there's a leg movement or something else that's going to trigger an arousal, they would resort to bruxing initially. But then that wasn't sustained. So I think at first there's a more global reflexive response that, but as your airway realizes it doesn't need to brux, it gets deconditioned, so to speak, as having the bruxing as part of the arousal phenomena, and then it will go away over time.
Okay, so like more of a phasic bruxism from a limb movement, or so in my mentor, this is what she taught me. I'm not sure where she learned this information, but we know that any oral habit can cause the body to release endorphins that are calming and regulating for the body. Thumb sucking, nail biting, chewing gum, right? So when the tongue's not resting in the correct position, someone might engage in these habits to help regulate, release that serotonin and endorphins. So she taught me that daytime bruxism is due to when the body's dysregulated. So you might be really hungry, tired, bored, angry, and you might clench or grind to release those endorphins to help put you in a regulated state. So we teach our patients, eat regularly, maintain good blood sugar. We have different techniques and different ways we question to see potential contributing factors. But nighttime bruxism, sleep bruxism, is due to any nighttime sleep disturbance. And we find the majority of cases that sleep disturbance is an airway related issue. However, it could be any other nighttime sleep disturbance, like we had a child who they had a hamster in his room in the cage, and the hamster would be awake at night spinning on the wheel, and the child was grinding the teeth like crazy, took the hamster out of the room, and the child slept soundly. It could be lights coming in the room. It could be sounds, spouse waking up and you start grinding your teeth. So we teach our patients, we look at all potential nighttime factors, even sugar, having sugar late at night can cause arousal so you don't sleep as well. So we address all those, knowing probably the majority is actually due to an airway issue, but any nighttime sleep disturbance could trigger that in someone who's a bruxer. So it kind of goes along with what you were saying as well, like a limb movement could trigger that, even if it's not an airway issue. So that's really fascinating to me. And we have a really detailed questionnaire for daytime factors and nighttime factors. And we have our patients address them all, like address all these potentially related factors, even though we know at the nighttime it's probably or sleep could most likely be an airway breathing related component. But our patients, we get them earplugs, sleep mask if they need, white noise machine, cover room darkening, we make your room like a cave, dark, cold, quiet. Get your spouse to not make sounds when they're coming in and out of the room, dim the lights an hour before, but like we target all those aspects of sleep hygiene. So it just was interesting to me how you just talked about a component that might not be airway related, and you find some people might have that phasic bruxism due to like a periodic limb movement.
Well, if they're conditioned to bruxing as part of a preservation phenomena, because, with the airway, but then when you resolve the airway component, then that goes away. So it would be while you have the airway so you're what you've described are eliminating the other causes of fragmented sleep, disruption of sleep. I don't know, I'm not sure how much the sugar itself would play a role, but clearly the hamster in the room, other kind of environmental factors, yes, that's someone that's already conditioned to having the bruxing as a way of helping to resolve the disturbance of whatever triggers the arousal. So it's in response to the arousal. But
Yep.
once the airway component is resolved, then those other things would extinguish over time.
Possibly, yeah. And she portrayed it as like that serotonin that or that endorphin release from the oral habit will help put the body back to sleep. So for someone who is a bruxer, if it's not an airway related issue, but some other sleep disturbance, they might clench or grind to release those endorphins to help regulate the body, get them to go back to sleep. Kind of like that sort of post-arousal like phasic. It's an
So,
interesting thought.
so since we're talking on this topic, let's touch on something that's real important that people be aware of. A lot of kids are going to go and have orthodontics done. And when you get the history, you find out that after the orthodontics are done, that's when the bruxing started, right? And that, that's the minority, obviously, of cases, but I clearly have heard that many times. And these are individuals that have had retractive orthodontics. And usually if there's extraction done. And, we're trying to get it to where that, I guess that the extraction, retraction orthodontics is sort of the standard of care, but really when the standard of care may be putting someone at jeopardy of making their health worse, we have to change what the standard is. And there's a lot of things that are going on right now, a lot of debate within the field on that. And so, but clearly from a parent's perspective, if they see that after the orthodontics, the child starts to grind and clench, that's an airway issue. Whatever was done orthodontically now is making that now a compromised airway, and the child's trying to create more space and grinding and clenching. But what about those individuals that have orthodontics and then they, without that nighttime retainer, they're starting to splay out their teeth again? And they get all the spaces. Why? Because their tongue is thrusting. Why? Because it's trying to clear the airway, because the kind of orthodontics didn't make space for the tongue, right? And so I think people need to become much more aware of what's going on in the airway and realize that orthodontics plays a crucial role in the anatomical structures, in the volume of the space, and how the tongue plays a role, and all that's part of the upper airway. And this part of the anatomy is not just dental, it's medical, it's all one. It's part of the being human, and we function on a fashion where everything is interrelated. And so we're hoping that there's an elimination of this routine retractive orthodontics, and it's more expansive to make room for the tongue.
Allow for the best breathing as possible. Make room for the tongue, bring those jaws wide forward to help that person breathe better so they're not having symptoms like bruxism, which is a reflection of them struggling to breathe. And I think thinking of adults, restorative dentists need to be aware of this, knowing that as they're, putting crowns or fixing cracked teeth or repeated issues like that, that a lot of this could be due to bruxism from an airway issue. I think a lot of restorative dentists do get their aha moment when they realize that. I've had patients who have had so much expensive dental work from bruxing. And I believe one lady had like $80,000 of repairs on her teeth before anybody diagnosed she was an airway case. She was just cracking, breaking her teeth because she was struggling to breathe at night. So that's an important aspect for a restorative dentist to be aware of. Um, and it's interesting that you also stated when someone stops bruxing, they might not be protecting their airway anymore. So the sleep breathing issue may get worse. These are some points I'm like, wow, this is interesting. Also, the home sleep testing for sleep studies, you like to call it the home sleep apnea test instead of home sleep testing, but HSAT, because it can rule in sleep apnea if you have sleep apnea, but would not rule it out. So if someone has signs and symptoms and they do a home sleep study and it comes back fine, it doesn't mean you're off the hook and you're fine. Doesn't that mean they should go into a lab for a real sleep study?
Yeah.
Okay, because I've
Okay,
had
real.
friends.
No, right.
Yeah.
Have it right. In some ways, so when it's interesting to say a real sleep study. So it's the brain that sleeps, right? And to identify whether someone's awake or asleep really requires brain activity measurement, okay, EEG. And then to stage that sleep, whether it's, what stage of sleep it requires also eye movement measurements and muscle tone measurements, right? And you can identify if the person's in REM sleep or not. And there's certain characteristics of stage one with certain types of eye movements also. So, you need those three parameters, EEG, EOG for eye movements, and EMG for the muscle activity. Anything shy of that, those tests have been identified to be associated with wake and sleep and the different stages of sleep, but it's not definitive. They can be wrong, right? And so on a home sleep study, the home test may think the person is asleep because the breathing pattern is a certain way in relationship to their heart rate pattern, and they're not moving around a lot. They could be in a deep state of meditation and still awake, and the muscle tone of their upper airway could be still increased. And so they're not going to necessarily be having obstructive breathing, but the device may say that they're asleep. So it really doesn't know. These are, and then when someone's trying to talk about how much REM they have or non-REM or slow wave sleep, deep sleep, and they're looking at, these other home devices that, they really don't know. So you don't want to over-interpret the information when the information itself is limited to start with.
Yeah.
Right?
Okay. Very important for people to know that if that home sleep study comes back as fine, that they should follow up if they're symptomatic.
Let's talk about the Apple Watch for a second. Okay. What's real important, because people will wear the Apple Watch saying, oh, it shows that I don't have sleep apnea, so I guess I'm okay. That is so far from the reality. It's the other way around. If your Apple Watch says you have sleep apnea, you've got a lot of sleep apnea. It's not mild, right? The Apple Watch uses movement for detection of sleep apnea. It doesn't use oximetry, it uses movement. And it's sort of a repetitive movement pattern over a 30-day period to see this periodicity. And when they validated it to home sleep studies with a 4% oxygen drop associated with the events. I said earlier that you don't have to have any drop in oxygen, but the only events that they used to validate the Apple Watch were those events that were associated with the 4% drop in oxygen, right? And what they found is that the Apple Watch was going to be consistent with the home study, all right, with only a 66% sensitivity. So only 66% sensitive if for a 30-day period of showing this pattern. If when you're comparing it to an apnea that's moderate to severe using the 4% drop in oxygen. So if you were to, so there are so many, when the home study says that you have a AHI of 15 or higher with the 4% drop, it is severe. The device will say moderate at 15 is the beginning of moderate, but when you bring those people into the lab, you find so many more events that are missed by the home study, right? So that's what they use as their standard, and it was only 66% sensitive against those individuals. So I
If you use the Apple Watch and it shows sleep apnea, it's going to be severe.
it is severe. But if it doesn't show sleep apnea, by no means should that be a sense of reassurance that you don't have sleep apnea. And that's my concern. Is people are going to say, oh, I got an Apple Watch and it's not showing that I have sleep apnea, so I guess I'm okay. In the meantime, they have hypertension, they're falling asleep behind the wheel, then they're sleeping fatigue, but they think it's not from sleep apnea because their Apple Watch doesn't say so.
Yeah.
That's the important message that I wanted to get out.
Extremely important message. Couple things back to bruxism is what's the relationship between medications and bruxism? Like I've heard SSRIs like Prozac or things like that could cause sleep bruxism. Is that true?
Well, certain medications will increase muscle tone.
Okay.
So as an underlying cause, I don't believe it is. I think it's an augmentation of an underlying stimulation, but you will get certain medications, and SSRIs can increase muscle tone. All the antidepressants actually have a tendency they're all anti-REM actually. And so you can actually get increased muscle tone in REM sleep. And you can actually get REM behavior disorder as like tricyclic antidepressants can cause REM behavior disorder. So
but not upper airway muscle tone. Like, would it help with breathing
okay, so I don't want, let's revisit this because there's some studies being done with certain medications that are being reviewed and going to be getting some FDA approval probably down the road that may increase muscle tone of the upper airway. And I think it would be inappropriate at this point to start giving some speculation on some of the aspects of some of these things. But there may be medications but the thing is, will those medications also cause more arousal? How are they going to function in your overall sleep architecture? But there are medications that will increase upper airway muscle tone, and even some of the cannabinoids might actually do that. But I don't really want to go into any great detail at this point in time because I think people can misuse information and go down the wrong path.
Okay. With the SSRI, so when you say increased muscle tone, upper airway muscle tone?
Well, not selectively, but yeah, it can.
Okay.
And years ago, that was a treatment that people were doing is using tricyclic antidepressants along with serotonin, or sorry, tryptophan for treating sleep apnea. And it was early, we're talking about in the 80s. There were some treatments being recommended then, but so there is some literature out there and some basis, but it's not the proper way of going about treating these conditions.
Okay, as we wrap up, do you see worse bruxism in people with upper airway resistance syndrome versus someone with full-blown apnea?
We never really sorted it out that way.
Okay.
I can't say that that's the case.
Okay.
But what I would say is that there are a lot of patients that, let's say, thin women with high arch palates, small mandibles, that they have upper airway resistance syndrome. So the diagnosis of obstructive apnea is hard to make. And they're bruxing and clenching and they're having headaches and they have a lot of problems. And that's where we really need to use the PES because we could then characterize the airway dynamics much better. And we might find that there's only certain points during the night where they clearly are not bruxing and we see the increased obstructive breathing. Okay. And so the overall frequency of the events may be low, but that association is clear. Okay. And then by treating their obstructive breathing, the clenching improves.
And this is my last question that I'm going to let you go because you have probably a million things to do. But if someone doesn't think that they clench or grind their teeth at night, but maybe their dentist has told them they do so, what are some signs that a person might maybe sleep bruxing or bruxing while they're sleeping?
Well, aside from waking up with pain,
okay.
Notice, let's say, a little bit of maybe scarring in the inside of the mouth, the tissue where they're catching it, or they may have developing tori, like the actual bony growth that's inside their mouth from the pressure that's occurring, or they may develop they should see the wear pattern themselves. All right. And the thing is, those wear patterns are not going to heal. So someone may have done it in the past and maybe not do it anymore. So the aging is difficult. Then abfractions, where you get the bone loss right near the gingival line, again, from the pressure that's occurring. And so these are signs of bruxing, and then just a bed partner may be telling you that they hear it and that it's going on. But
and potentially headaches, right? When you're waking up with headaches.
Yeah, waking up with a headache, a muscle tension headache.
Okay.
And they're going to see the neurologist who's going to be putting them on all. It could even be triggering migraine. Apnea can trigger migraine. When if you're seeing a headache specialist, and most of your headaches, you're waking up with headache, and your headache specialist hasn't asked you any sleep questions, hasn't screened for sleep issues, then you got to go to another headache specialist or go to a sleep specialist, because unfortunately people are in silos and they only understand what's in front of them, and headache specialists need to understand that sleep can be intertwined with headaches and the frequency of headaches.
Yeah. Wow. What a great interview, Dr. Simmons. Thank you so much for all that information on the Sleep Education Consortium. Everybody should definitely attend April 3rd through 5th. And you'll learn so much more about all these areas and a variety of topics. And I really appreciate this really detailed discussion about bruxism. I think it's going to help not only practitioners, but also patients and parents. I think a lot of people aren't aware of all these details and just put a night guard on their teeth, or just say, oh, bruxism, it's normal. Kids grind their teeth. Really, it's a sign of an underlying
night guards, right? So that like the little, NTIs or just things, they don't help the airway.
They can make it worse. I know studies show 50% of cases a flat plane night guard will make the sleep apnea worse. Thank you so much for your time. Really appreciate it. You are the best. Have a great rest of your day. Thank you.
Thank you.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.